Here, inspiratory muscles are diaphragm and external intercostals. We talked about how those change the shape of the thoracic cavity. The external intercostals have this oblique nature. Remember, the fibers are going in and down. So when they contract, they move the rib cage up and out. The diaphragm, again, because of its dome-shaped nature, when it contracts, it flattens out. Whereas during expiration, the internal intercostals and the rectus abdominis, so the core muscles or the abdominal muscles, they will help they will contract during forced expiration to change the shape of the thoracic cavity and to influence the pressure to move air out, okay? Now, these are not always involved, right? There's something called quiet expiration. So if you're sitting quietly, breathing in and out, you're actually not engaging your cores, you're not engaging the internal intercostals. Expiration is pretty much a passive process, but if you're doing more of a forceful expiration, these are the muscles that become engaged. Okay, and we can see these muscles here, right? So the external intercostals, and we should know this from lab. We know that the orientation of the fibers are down and inward, and that creates this dragging up and out that happens when those muscles contract. The diaphragm here, which is this large dome-shaped muscle. And then we can also see the abdominal muscles here, the rectus abdominis muscle, and then the internal intercostals have fibers going in the opposite direction. So these guys are in charge of inspiration, and these are in charge of forced expiration, right? Quiet expiration does not involve these muscles. Okay, so just to reiterate this volume change that we keep speaking about, right? So the diaphragm here, while it's contracted, is flat. And we can see how the chest wall is much wider in terms of the diameter. And that actually pulls on the pleural cavity, which pulls on the lungs, opens up the alveoli, and drops the pressure in the alveoli, and air can rush in. In expiration, we do the opposite, right? We relax those muscles. So when the diaphragm relaxes, it goes back to its dome shape. The external muscles, external intercostals relax, and they bring the thoracic cavity back to that natural shape. And we can see the diameter here is much smaller, so that squeezes down on the lungs, squeezes down on the alveoli. And if we decrease the volume, we said we're going to increase the pressure, which drives air in the opposite direction, okay? Now we can engage other muscles for more forceful inspiration and expiration. So if you're in respiratory distress, again, something like asthma or emphysema or COPD is another big one, you engage your neck muscles, and the neck muscles help with making the rib cage even bigger, right? So the neck muscles that are attached to the sternum will pull on the rib cage and help get air in any kind of obstruction or any type of inflammation that we see with asthma and so on, okay? So you'll see those people who may be in respiratory distress, what we call neck breathing. They sometimes do tripoding. So they lean over and they're really trying to get the rib cage to get as big or open as much as it can. Okay, so here in inspiration, let's speak about some of the stimuli for inspiration. So we know that there's neural stimulus involved. Now, what type of muscles are the diaphragm and external intercostals? What type of muscles are they? Yeah, skeletal muscles. So what type of innervation or neural stimulus do we expect to see? Is it autonomic or somatic? Somatic, right? So we're going to see somatic involvement here, which innervates these muscles. So those are the types of nerves. What nerve? Does anyone know the nerves to the diaphragm? Okay, we haven't gotten there yet. So the phrenic nerve is the one that innervates the diaphragm, and that is what is going to send stimuli to the diaphragm to flatten out or to contract. So basically we have the collective nature of these muscles working together to change the volume of the thoracic cavity. And let's talk a little bit about how the pleura plays into all of this. So the transpulmonary pressure, which is derived from the intrapleural pressure, is also being manipulated here in all of this. We talked about the fact that there must always be a negative pressure in the intrapleural space with regard to the alveolar pressure. And that is because the pleura actually pulls on the alveoli. So even if we have those muscles expanding and they're not directly engaging the alveoli through the pleural connection, then we will not expand the rib cage, we will not expand the alveoli. So having the muscles that we talked about pull on the pleura, that decreases the intrapleural pressure, which increases the transpulmonary pressure, right? So if you look at this, where is it? Okay, so if you look at the relationship between the alveolar pressure and the atmospheric pressure, if we increase the intrapleural pressure, then we decrease the transpulmonary pressure, right? Because there's a difference there between alveolar and intrapleural pressure. So decreasing the intrapleural pressure increases the transpulmonary pressure. And what did we describe the transpulmonary pressure as? The distending pressure, right? So that's the ease with which the lungs want to distend. So we need to keep this number up. And if we increase intrapleural pressure, if we make the intrapleural pressure more positive, then we decrease the transpulmonary pressure. And so the lungs don't want to distend, right? That distension pressure decreases, and that makes the lungs very rigid, very hard to distend, right? So we really want to keep transpulmonary pressure up, and we do so by keeping intrapleural pressure down. We also want to talk about the alveoli expanding. That happens when alveolar pressure is decreased, and that is what facilitates airflow into the lungs, again, according to that pressure gradient that we described. Okay, so let's just walk through this flow chart of events. This should help summarize some of what we spoke about. So the neural input is the first, I can hardly see this. The neural input is the first stimulus involved. And again, that's coming from the somatic nervous system. Although we can influence the breathing using the autonomic nervous system, so when you're asleep, you're not actually engaging in respiration. We have the respiratory centers and the medulla that kick in. But for now, what we're speaking about is you actually controlling your respiration. Later on, we're going to talk about how the respiratory centers play a role here, okay? So the inspiratory muscles are engaged, diaphragm and the external intercostals, they contract. And we talked about how they change the shape of the chest cavity. This creates expansion in the chest wall, which makes the volume of the thoracic cavity larger. And that actually pulls on that pleural cavity, which is pulling on the intrapleural fluid, increasing that pressure. And then that will decrease the intrapleural pressure, which increases the transpulmonary pressure, okay? So decreasing the intrapleural pressure increases the transpulmonary pressure and makes the lungs really want to distend, because we talked about this being that distension pressure, okay? That will then create the alveoli to increase as well. They're going to increase in their volume, right? They're going to sort of expand or open up. And what will that do to pressure? Increase or decrease? Decrease, right? Increased volume decreases pressure. So we decrease the alveolar pressure, which does what? What's the next step here? If we decrease alveolar pressure, the next sequence of events. We facilitate airflow, right? We now have a gradient, so now we facilitate airflow, which moves air into the lungs or into the alveoli, okay? Now we can also speak about the negative feedback event here. So as we increase the alveolar pressure, then that slowly becomes back to its normal state because air is now moving into the lungs. And I talked about the fact that this is not a fixed state. So the alveolar pressure does not stay in any one state. So as soon as it's increased, as soon as the gradient is achieved, it begins to increase as more gas molecules come into the lungs, okay? And that's how we get back to our original state there. Okay, now on this slide here, we can compare the intrapleural pressure and the transpulmonary pressure. So that last bit, I think, is where a lot of people are often confused. How do we influence intrapleural pressure and transpulmonary pressure? So we talked about this pressure here. This is the intrapleural pressure, that pressure in the pleural cavity. We talked about it always being more negative than the alveolar pressure. We also talked about it being -4 at rest, right? So we can see it at rest, which is on either side of this, it's at -4. And so when the intrapleural pressure is decreased, we increase our transpulmonary pressure. and the lungs really want to expand in this phase. But if we decrease our intrapleural pressure, if we increase our intrapleural pressure, we decrease our transpulmonary pressure, and the lungs don't want to expand in this phase, okay? So intrapleural pressure and transpulmonary pressure can also be said to be inversely related, right? Increasing the intrapleural pressure decreases the transpulmonary pressure, and increasing or decreasing the intrapleural pressure increases the transpulmonary pressure, right? So they're inversely related, okay? We can also see the relationship here that we described, Boyle's law, right? So what did we say Boyle's law to be? What did we describe Boyle's law to be? Pressure and volume, yep, are inversely related as well. And we can see that relationship here. So as pressure decreases, volume increases, and as pressure increases, volume decreases, right? That nature of the thoracic cavity to influence these pressures, okay? All right, any questions here? Okay, I think this is the last thing that we'll talk about. So I think I mentioned a little bit of this earlier, but I'll just briefly touch on it again. Expiration is typically a quiet, passive process. So all we have to facilitate expiration is the relaxation of those muscles that were contracted during inspiration. So relaxation of the diaphragm, relaxation of the external intercostals. That is usually enough to facilitate expiration. But if we want to expire more forcefully, we have to contract those inspiratory muscles that we talked about, which are the internal intercostals and the abdominal muscles, okay? And if you ever try to take a really forceful breath out, like you really try to blow all the air that you can out, you'll actually feel your abdominal muscles contracting to help engage that process, right? To empty the lungs completely. Okay, we'll pick this